Good morning to everybody. So glad to see so many of you here today for today's medical grand rounds. Also just wanted to put out a reminder for next week's talk. We'll be having our annual Donald E. Olson Memorial Visiting Lectureship, and we will be hosting Dr. Clarence Braddock from University of California, Los Angeles. He'll be discussing the expanding importance of shared decision-making and patient engagement. Today, we're very eager to have with us Dr. E Gunn. She's a practicing internal medicine and occupational health physician and is founder and owner of Occupational Medicine here in Portland, Oregon. She earned her medical degree from University of California, Davis, did residency in internal medicine at Providence, Portland, and later residency in occupational and environmental medicine at University of Colorado in Denver. She previously had earned a master's in public health in environmental health sciences at UC Berkeley and had extensive experience in environmental health and safety prior to attending medical school. But really, apart from that, Dr. Gunn is here today as a sister and a person and a physician to lend both her personal and her professional perspective to the very important topic of patient safety and medical errors. So welcome, Dr. Gunn.
Thank you for having me. In 2013, a horrific story came out of the San Francisco hospital when a confused patient wandered into a little-used stairwell and died. Later, it was learned that a hospital employee had stepped over her body twice before informing anyone else. And even though the employee informed a nurse, and she informed security, they still didn't find Lynn for another week. That was in 2013. An extreme example of medical errors for sure. As a physician, I've been very aware of medical errors, but it wasn't until 2014 that medical errors came knocking at my front door. My older sister, Anna, she'd had her health struggles. And so I want to share with you our story of 2014. It was Tuesday, May 27th, the day after Memorial Day. And shoehorned between two trips, I knew my occupational medicine clinic was going to be wildly crazy. The afternoon before, I had spent it with Anna. She'd been at an inpatient at a well-respected teaching hospital for 23 days with both cardiac and neurologic issues. However, she was recovering and doing quite well. She'd been under their care for the past year and a half, and a year prior, she'd had a bone marrow transplant. And just before she was hospitalized, she'd emailed her attending physician saying, you know, my specialists are only considering me as body parts, and no one is looking at me as a whole. That morning, that Tuesday morning, I had patients in each of my exam rooms. The phones were ringing off the hook, and it was basically crazy. And the following day, I was to fly to Philadelphia for a business meeting I didn't want to miss. While I was in the back charting, I could hear my cell phone buzzing. And it was the bone marrow fellow contacting me and saying, you know, Carol, we're getting ready for Anna's discharge, and we want to be sure that she can come and live with you after she's discharged because we think that makes the most sense. And I said, absolutely. She and I had already discussed that. She was a single mom to a college-age son, and it just made the most sense that I was with her during her convalescence. I got back to my patients. I also had a corporate client on my schedule that day. Worked the morning, and at lunchtime, I met with my corporate client. Again, my cell phone started buzzing, and it was the bone marrow fellow again. And he said to me, you know, we think there might be something going on with regards to Anna's heart, and we're going to have to take her back to the cath lab. A bit dismayed, but really more upset that she had to go through yet one more procedure, I hung the phone up and tried to return to my day's events. A few hours later, I got another phone call. This one from the social worker who said, there's been a change in Anna's health status. I'm like, yeah, I know. She's got to go to the cath lab. And she said, they're coding Anna right now. As a physician, I knew she would never survive. I actually said stop, and I actually gave a few four-letter expletives along with that. A few minutes later, another phone call came through, and this time it was her attending physician who informed me that Anna had officially died. My head was spinning. I was on a roller coaster of emotions. I could barely catch my breath. My heart physically ached. She was my lifelong and closest confidant, but worst of all, I had to call her son and tell him, my nephew, that his mother had just died. She died before ever getting to the cath lab. Her autopsy stated that she had died from long-standing cardiac disease. Her autopsy also showed that she had normal bone marrow and no cancer. However, I knew the pathologist was wrong. As a very close family member, I knew Anna's health history quite well. She didn't have long-standing heart disease. She had some risk factors, but those were well controlled. And now they're stating her death was from long-standing heart disease? So I was driven. I was driven on a road to figure out what really caused her death. At my request, the hospital gave me her medical record. It was 14,000 pages long. My investigation continued. I sat with Anna's best friend, my nephew, and we discussed doctor visits that we had all gone with her to. And I drove all over Marin County collecting additional medical records so I had a full picture of her health. And after reviewing her records for countless hours, I found some very unsettling findings. And that's what I'm going to share with you today, what I found and what I did and what I now know about patient safety. But prior to doing that, I want to share a little bit so you can understand from a medical point of view her medical history. First, prior to having myelodysplastic syndrome, that is why she had the bone marrow transplant. She had had breast cancer as a 43-year-old, stage 3B, significant. She was treated with high-dose chemo, autologous bone marrow transplant, bilateral mastectomy, and chest radiation. But she did really well on that. She had some risk factors, as I've listed here, hypertension, hyperlipidemia, but both were well controlled. And because of the chest radiation, she and her primary care doctor had been looking to make sure she was not having any cardiac issues, and so they did a coronary calcium score in 2012, and she was given a score of 0, low risk, which by estimates is 1 in 500 chance of having a cardiac issue in the next 5 years. After her diagnosis, she was diagnosed with a routine CBC, and it showed that she was having bone marrow failure. She was working full-time at that point in her life. She actually worked full-time up until her allogenic bone marrow transplant. She had a stress echo, which showed she had a normal EF, 60-65%, and then she had the allogenic bone marrow transplant in February 2013. She did great afterwards. She was in the Bay Area, and she had to move away from her home down near the hospital, and she lived in an apartment where she had to climb stairs, and she did just fine with that. She actually left there. They said, "You're good to go home." She returned home with her son. He was a graduating senior from high school, and then she started having these odd neurologic symptoms. They wondered if she was having partial complex seizures. She was having some cognition issues, and that was in August. She was admitted for some shortness of breath then, and then it just kind of progressed a little bit more. She actually did return to work, And then in February of 2014, she started having chest pain. I'll go through the chest pain scenario a little bit more later on, but it was in May 2nd, 2014, she was admitted to a community hospital. On that day, I called her. I was just checking in with her. I was due to take my boards on May 5th, and I had the day off to study. And she told me she'd been having some, it sounded like foot drop to me. And the day I called her, I said, "How are you doing?" And she told me, "I can't feel below my waist." And I said, "Anna, that's an emergency. You must go to the ER." I could hear her calling her son in the background, and that was the only time I heard fear in her voice. And she said, "Kevin, Carol says we have to go to the ER." And I knew she was frightened to death. She elected to go to the community hospital because she had felt like the teaching hospital had not been hearing her concerns. Actually, the teaching hospital had said to her in the February and March timeframe, "You know, you're doing great, and you just need to go back and reestablish care with your local oncologist and your primary care physician." So she elected to go to the community hospital, and then the community hospital evaluated her and said, "You're too much for us. You need to go back to the teaching hospital," which she did on the 4th, and she died on the 27th. So her social history, a single mom, now a college-age son. She was a financial planner, and she really had no alcohol, no illicit drugs, and no tobacco. So what did I find? You know, in my long and storied view of her record, I found a delay in diagnosis of her chest pain etiology. I found issues with her medical records, and I found communication problems between her and her providers. And so first I want to look at the delay in diagnosis of cardiac chest pain. I'm an internist. Someone tells me I have chest pain. I tell them they have to go to the ER. I'm a sister. Sisters don't always listen to other sisters, and she did not listen to me, and I know that. That's just the way it is, and she knows that too. She knew that too. Her chest pain complaints were not recognized by multiple providers. But when she did go to the community hospital, first time they had seen her, they did a full workup. They had looked at her cardiac issues, found elevated troponins and changes to her EKG. However, they shipped her up and put her back to the teaching hospital, sent her with a transfer summary, a printed transfer summary, and I believe an electronic transfer summary. However, that team never really looked at it. Even though it was the first item on the laboratory data that she had elevated troponins, they restarted narcotics for her chest pain, and I will show you that. And I think groupthink prevailed as they were rounding. So here are her outpatient visits. 63 days before she was admitted to the hospital, she had chest pain, saw the teaching hospital oncologist. He told her to try Maalox, and she was having some joint pains, and he began oxycodone and gabapentin for that. She saw a pain management specialist about a week later. Her pulse was clearly elevated. He writes a pretty good differential in his note, which was unusual in the notes to have any good differentials, if you ask me. He reported new middle chest pain radiating to her back and neck. He said it could be GERD or it could be graft versus host disease. He thought it was responding to gabapentin, and he noted that she had talked to the BMT attending about it, and so he recommended continuing gabapentin for it. As I said to you, her case was transferred back to the local folks, the local oncologist, and he reported in his note that she had sternal pain radiating to her back that required oxycodone. So let me just step back a few seconds here and say my own father was a physician, and we were raised that you were basically had to have your arm falling off before we would be recognized as having a problem. So we as a family, you know, my two sibs and I, we would not ask for pain meds unless we had a heck of a lot of pain. And so that was part of the issue here too, I think, is because she was late in telling people she was having pain, and they didn't recognize what that kind of history of ours was and what that meant. So at the community hospital, she had the mildly elevated troponin on day 1, And then on day 3, she had elevated troponin, and that was the day they packaged her up and sent her back. And then at the teaching hospital is where they noted in the subjective portion very clearly that she had chest pain for over 2 months. They called it sharp, whatever. And what their plan was to restart oxycodone. And so then, unfortunately, she got transferred back on a Sunday. And so both the fellow and the BMT attending both changed for the following day. And so she started having more and more physiologic changes that showed she was having problems. When I talked to her by phone, she said, I clearly told them about the chest pain, Carol. I know they know about the chest pain. Because that was one of the questions I had for her. And so on the phone, she was so short of breath, she would say, you talk, I can't. So she couldn't carry on a long conversation. And they really weren't looking at it. They were looking at her neurologic issues. So then it gets worse. She was monitored. She didn't have a full EKG. She was monitored. She had 2 runs of VTAC on hospital day 8. And so then on hospital day 9, appropriately, they started looking a little closer. They ordered an echo and a cardiology consult. Unfortunately, the echo and the cardiology consult both took 4 and 5 days to show up. So she still wasn't seen by a cardiologist until day 14. On day 14, she finally had a cardiology consult. On day 13, she had the echo, which showed she had an EF of 35%, and it had orthopnea and shortness of breath. And on day 14, the cardiology consult. And they couldn't locate any of her old cardiology records. And they wrote that in the note and said, but it would be unlikely she would have gotten a transplant without a normal EF. So they were operating on little information with her. And then the following day, she was taken to the cath lab for a stent. So are these unusual findings? Well, I start to go out and look to see what's really going on other places and what's in the literature. And current estimates of patient harm really don't include delays in diagnosis yet. You know, I don't know if you saw it, but in September, the Institute of Medicine released a new report on delays in diagnosis. And they stated 2 things in the report that I thought were pretty sobering. The first one is all of us will likely experience a significant delay in diagnosis in our lifetime. So the way I look at it is Anna's was lack of knowledge with regards to cardiac chest pain. The other very sobering statistic that they gave is 5% of all adults seeking outpatient care will suffer a delay in diagnosis or a diagnostic error. Her medical record, 14,000 pages long, and there are a lot of cut and paste. And locating outside records and locating the outside records and the transfer from the teaching hospital caused problems. So the cut and paste. So I'll just visually, I know you can't read it, I don't want you to read it. What I want to show you is how much was cut and pasted. This is just her plan, okay? Out of all the areas, you know, the subjective, the objective clearly was new information. The assessment and plan, the subjective had the most cut and paste. But I'm focused here on the assessment and plan because that's where you see the providers, what they're thinking about and what they're planning for the next days. So day 3 to day 4, some changes. And then day 4 to day 5. Day 5 to day 6, some changes. Day 6 to day 7. I mean, she's, you know, clearly very little changes is going on. And when I looked at the outpatient record, the cut and paste was so enormous, it was hard to believe. When I mentioned before that she had the question of whether or not she had a partial complex seizure, that was noted in her record in the September timeframe. And what it said was, in the last 2 weeks, Anna had an event. Every outpatient note, which was she was going down there probably 1 to 2 times a month, every outpatient note had that same line in it from September all the way through February, even though she only had 1 event. It was unclear what medicine she was taking. You could not figure out what exact doses she was taking because people were cutting and pasting and cutting and pasting. So the outside records, I already mentioned the cardiologist reported that he couldn't find the outside records. And of course, the medical record I received didn't contain any outside records. That might have been just because of what they sent me, and that they might have not sent that to me because they don't really own those records. It's not really clear to me. I will say, as a family member, I was active in their care. My name was listed in her notes on multiple occasions. I mean, the team knew I was involved, and it took quite a bit to have them release the records to me, even though I was her, while she was alive, her healthcare power of attorney, and I am the trustee of her estate. I had to request it multiple times to even get the records initially. So I mentioned it was, she got transferred from the community hospital to the teaching hospital on a Sunday afternoon. There was a phone consult, I know for a fact, between the two attendings. And I know from asking the outpatient, the community hospital, they say they always send a printed copy. I know she went with images, CDs of images, down to the teaching hospital. The teaching hospital attending did not go into the hospital the day that Sunday. However, he attested, as we do and as people do with regards to writing on fellows' notes or residents' notes, that he had been with the fellow, examined Anna, and been on the floor for over 70 minutes with her, making decision-makings with the fellow to decide for her care. I asked him why he had not been there, because I knew enough about her care. I was completely shocked when I saw that he was the one that attested, and he was even signing the admission note. It just was, completely blew me away. And he told me it was late at night. My nephew, when he was 20 at that time, in his wisdom, we were meeting with him. There were other employees of the hospital there. My nephew asked, how many times do you write notes on patients you don't see? I thought it was one of the best questions, and it took a young man to ask that. And the attending said, I see 95% of my patients. The fellow note was started at 4:57, and the fellow finished his note at 8:48. Her estate was billed for that visit. So are these unusual findings? You all know about cut and paste probably more than I do, since I don't work in a hospital environment. But in 2013, there was a report that looked at a retrospective cohort study about how much cut and pasting was going on, and it looked at over 2,000 progress notes. And it showed that people copying 20% or more was occurring with 84% of the residents and 74% of the attendings. Concerns have been raised for iatrogenesis, electronic iatrogenesis, and I think we really do have to start looking at that. There's many, many case reports in the literature now about incorrect patient information, and there's, you just don't build a good relationship with the patient's families if you can't speak to what's actually going on. If you say, oh, I see your spouse has been here for a week and they've been there for 3 weeks, that just doesn't give you any kind of credibility. ECRI partnership has written guidelines for cut and paste, and I know Providence has started looking at it with focused work, but there's not a policy yet. There's a letter dated from the U.S. Department of Health and the U.S. Department of Justice that, with regards to Medicare and Medicaid, you have to be accurate and you have to verify information. I mean, because you're billing against that you've done a certain level of work, and you can't claim work that you haven't done. So issues with outside records and transfer of care, is that new? We all know when patients get moved from one place to another, that is when mistakes can happen, more likely to happen. And so we all recognize that potential. In a health policy brief, Reducing Waste in Healthcare, 12% of our healthcare spending is in failure of care errors, as well as failure of care coordination and fraud and abuse. So there were communication issues between her and her providers. You've heard that already. So is that unusual? Well, I looked in the literature with regards to that too, and I found some interesting studies. Some of them kind of old, but I'll show you these three. From the patient point of view, listening serves three purposes. It enables physicians to make accurate diagnoses. It creates and maintains good doctor-patient relationship, and acts as a healing and therapeutic agent. Our patients get it. That's true, An old study, this is the old one, 1993, about frustrations of physicians. Physicians were frustrated, 33% of physicians were frustrated in up to 25 patient encounters, 25%. 8% were frustrated in up to 50% of the patient encounters. And the most telling one of all for me is most often the physician attributed it to the patient and didn't attribute it to themselves. And lastly, a recent 2013 national survey reported, and I think next week's Grand Rounds, it would be interesting to hear what they have to say with regards to patient engagement, but patients are not feeling a high level of shared decision-making, even in primary care over medications and screenings and things to that extent. I'll give you one recent, it's anecdotal, I get it, but I failed to get my Tdap, okay? And in 2000, early last year, about this time, I had a significant cough. And thanks to Dave Gilbert, who taught me that if you have a significant cough and the person is no longer continent of urine, you have to consider whooping cough. My primary care doctor wasn't available, so I went to urgent care. And at urgent care, I very clearly said at least multiple times, I think I have whooping cough. In the end, they did give me antibiotics, and I still was pretty sick for a while. I thought it was weird that there was no discussion about, because whooping cough is endemic, there was no discussion about maybe people I might have exposed or things to that extent. I'm an occupational physician. I went back and had my MA go to, under workers' comp, go and get a Tdap as well as a prophylaxis, and I had just visited my nephew and called his physician and asked for him to have the same. I was sick enough that I ended up asking to see a pulmonologist as well as an infectious disease specialist over at Providence, Portland. But what really got me was they said, "Why are you here? We can't figure it out from your medical record." I went back and got the urgent care notes, and whooping cough never was mentioned. So I say to you, if someone who can give a pretty good history has a pretty big concern about an endemic disease, if the physician is not noting that, then we have some problems. So what have I done about Anna's case? I went back to the community hospital. They nailed it. They got it right. They wrote great notes, had good differentials in each of their notes. They got it right. What do you do when people get it right? You send them thank you notes. You tell them, this is what you did really well, and I really appreciate it. What did I do with the teaching hospital? Wow, that was a big story. It took forever for them to even hear me. Anyone that dies on their service, they say, well, we'll meet with you. So I met with the inpatient attending. I met with the outpatient attending. I raised issues. I said, we have some really strong concerns here. Didn't feel like I was getting anywhere. So then I looked on their website. Hard to figure out where to go. I started searching. I found their patient safety clinician by writing a few key words and finding where he had written up a story, and I sent the case to him. He heard it. Not much comment back. The financial folks were calling me saying, she's got a lot of copays that you need to, her estate needs to pay. And I'm like, this isn't making me feel right. I said, I'm not going to pay anything until I know this has been investigated. The patient safety clinician, he had his boss call me. I thought, oh, great, finally someone's hearing me. And the boss had not even looked at the case and had no knowledge of the case. And so I was basically at step one again. They did offer me the opportunity and her son to get counseling. That was in January. She had died in May. They offered counseling to us. And then they offered me the opportunity to write up her case as a graduate medical education module on patient safety for them. But of course, that was on my own dime. Frustrated, I just kept going and trying to figure out what to do. A friend of mine told me about a patient safety clinician, Dr. Michael Leonard, and I spoke with Dr. Leonard, and he suggested I package it all up and send it to the risk manager. And that is what I did, the president of the risk management at the hospital, and that is what I did. Once I did that, they put her case through their PEARL program, the process of early assessment and resolution of loss. And on their website, they said that they like to put people into that within 4 hours of the event. So I'm still in the process of the PEARL event. She had an autopsy, as I mentioned. I asked the pathologist, did you notice that it took, days between the request for a cardiology consult and a cardiologist coming, or days between when the echo was ordered and it actually showing up? And he said to me, no, I hadn't noticed that. And that was about 2 months ago, and he was going to go back and look at that and share that with the team. And recently, I have been working with, just in the last week or so, with her insurance. So the PEARL program actually came back to me after a full investigation and working with me. They asked me where I thought the issues were. And they said to me, you're right, she did have a delay in diagnosis of cardiac chest pain. And so they relieved me, and not me, but since I'm the executor of the estate, they relieved her estate of the copays. That was in March of 2015. That great, okay. And then as a sister with a loss like this, or a family with a loss like this, there are certain dates that are much more difficult than others, and holidays tend to be those dates. And of course, that's when the bill from them came again. The week of Thanksgiving, I get a bill that says you owe us $8,000. And on that bill, one of the line items was for the H&P from the attending that never showed up. So a very strongly worded email went back, and of course I did not pay it. On the other side of it, I've been reaching out to experts in the field and trying to understand the whole issue of patient safety. I want to talk a little bit about that. And I've been reaching out kind of on the other side, not just within the professional community. I actually did a TEDx in front of 2,000 of my closest friends on medical errors. So, but what have I learned about patient safety? Well, the IOM kind of started the basis in 1999, and they had an estimate of up to 98,000 deaths per year. And in 2013, in Dr. John James, who actually lost his son, a young son, I believe in his 20s, looked at that number and realized that it was actually probably close to between 200 and 440,000 deaths per year. What do patient safety experts really estimate it to be? It's probably close to 200,000 a year. But that doesn't include delays in diagnosis, and that would be our third leading cause of death in the U.S. Lucien Leap, Dr. Leap, is the father of patient safety, and I think it's really important what he says here, and that is the focus on numbers is a sad diversion from the work of safety. We do not make hospitals safer by counting bodies. So what do I want from you? And what do I want from the healthcare folks? I will say one thing first. Losing, as a physician, losing a family member to medical errors is probably very similar to a military person losing a family member to friendly fire. It cuts really deep. It changes your relationship with your career and everyone around you. And you need to know that, because I really loved medicine. But to be standing before other physicians who look at you blankly, who are, I'm sorry you lost your sister, who are unwilling to dig a little deeper and say, what went wrong here? And what do we need to change so it doesn't happen to another person? That's what the families want. I'm never going to get Anna back. But I am not yet certain that there are processes in place that the same thing's not going to happen. Someone just like Anna. And that's the issue for the families. And so if you are a healthcare executive, I need people to stand up with resources and manpower. You need to lead with transparency and accountability. We know our providers are just stretched to the max. You can't just load one more thing onto the providers. We need to figure out a different way to do work. We need them to be providing and being responsive and less overwhelmed. And if you're a provider, I need you to listen to what people are saying to you. They didn't listen to Anna. That urgent care visit person didn't listen to me. We know physicians and probably other healthcare providers are very frustrated in their positions. If you're frustrated, you can't hear. We need to document care like you'd want your loved one's care documented. If your note stands up to the idea that it's okay, your mother would approve of your note, then that's the note you should be writing. You need to confront your colleagues. How many people have had people come to you and say, you know, I think you might have done that wrong. And we're talking about work. We're not talking about you as a person, but you want to know if you think of errors been made so that you can change it for the future. And right now, we don't have that closed loop. We do not confront one another over cut and paste notes or delays in diagnosis. But it's a gift. It's a gift. It was a gift that we gave to that teaching hospital when we said to them, you missed Anna's diagnosis. And the gift is so that another person won't have the same thing. Could it happen here? You know, we've all made mistakes. I have a list of them. I know patients that, you know, I wish I had done something else on. You know, I don't always know their names, but you just don't forget them. Medicine is increasingly complex. We all need that laser focus, and it's hard to have that day in and day out. But the biggest thing for me is we need the closed loop, and we certainly don't have closed loop systems right now. So we need to engineer ways to make work safer. So could it happen here? Yeah, I think it can happen at any healthcare institution. Thank you. I'm willing to answer anything, practically. Yes.
I'll start.
Good.
So first of all, thanks for this. Thanks for this really intensely personal story, but for helping to draw our attention to the stuff that we all are acutely aware of and struggle with monumentally. You know, I'm struck by this sense that while in many ways things have gotten better, we talk about these things in a way that we didn't talk about 10 years ago, certainly. And yet, we don't seem to be making a lot of progress on these things. I mean, the numbers you cite, I think are, you know, I certainly similar statistics presented, that we have underestimated the impact of this for quite a long time. So given that we seem to be more aware of it, we seem to be investing more time and energy into it, more money into it, we seem to be going backwards. And I just wonder what your thoughts are on that. And then the only other comment I would make would be that many of the things you point out here are, and I say this kind of as I hope, a note of optimism to both you and other people in this room. More and more we're aware of these things, and issues around such as transparency, propagated notes, those things are coming under incredibly close scrutiny within our own organization and nationally. And we are not far away from notes being open to patients where they can read their own record online or whatever. And this whole notion of the electronic medical record, we thought it would make life easier for us. We thought it would do things to our benefit, but it has created problems, as you described, with note propagation and other things. So that's just a comment. I think we're heading in the right direction on those things. But getting back to my question, maybe you have some thoughts on why we're moving backwards on this.
Why might we be moving backwards? I actually think it goes to the whole idea with regards to the closed loop system. So you all heard that I had a different career first before I went to medicine. I worked as a health and safety engineer in a high-tech industry. And so if we had a near miss or we had an accident, we would call everyone in the room at that moment in time and figure out why. And look at engineering ways to correct it. Because we can't depend on policies and people because they're tired and maybe something's going on at home or other things to that extent. So you have to practically engineer it so that people are successful versus depending on their memories or depending on them following a policy. Much more difficult. So when I worked at Intel in Northern California, we would spend probably 3 or 4 days with 15 people in the room if we had a major near miss and figure it out. And then afterwards, we would share that, and oftentimes with our competitors. We had, silane is a highly explosive and flammable gas, and if we found a problem with silane in we would then send it out to the other folks so that they knew it too. Because you have to share this information. So, and we all take risks. And you may say, no, I don't take risks. But we do. And I heard someone recently say that there's actually a biochemical rush in the brain when we do it. And so I say to you, and this is the way he explained it too, how many of you here drove to work today always under the speed limit? Thank you. Thank you for driving under the speed limit. A known risk. We all decided, maybe that risk isn't, I know it's a bit of a risk, but I'm willing to take it. So we put providers into situations where they've taken the same risk over and over and over again. What did they get from it? They might have gotten the note done faster and sooner and got home to their own family. And so we have not, they're going to repeat that same because it's been successful. And it's only when something blows up in your face, you're like, oh, now I've got to fix everything. And so the issue is really trying to find the near misses and talking about the near misses versus talking about when things have gone really south. I mean, mind you have to talk about these too. But if you have a nurse on the floor, I mean, I can't even imagine being a nurse on the floor. They are working their tails off. And sometimes we give extra kudos to nurses who can figure it out and can make the system work for them. Well, we really don't probably want that. What we want is to know where the problems are. We don't want the nurse to run 20 different places to find, that normal saline. If it's not in the right spot, then the hand should be raised then and the manager should be figuring out why that's the case. But sometimes we reward people for workarounds. Oh, she's great. She gets it all done. She's fast. And in fact, we really want her not doing workarounds. We really want the small little failures to occur so you can fix it. And so sometimes we're focused into the wrong place. And I think that's part of the reason why we're still having problems. And the last thing is, I will also say, I think the EHR introduced a huge, huge amount of problems that were unexpected. Yes, sir.
Did you have any occasion to look at other systems, other countries, France, Scandinavia, where data usually are better than our own?
Haven't yet. I'm starting to. I was suggested that to me yesterday to Canada, but I do know I have a Google alert now set up so I can see what's going on, and I know the UK is struggling with errors, as is the Canadian system. So, but I haven't looked in depth yet. Yes, sir.
I may have missed it. Did your sister have her own personal physician?
She did have her own primary care physician, but in their system, when she went to have a bone marrow transplant, the teaching hospital basically took over everything about her for a period of time, okay? And then they re-released her. They said, your numbers are great. You're doing well. And I remember I actually called down there. And, this is, when I think back on it, I said, she's not doing so great. I called the nurse manager, and she knew I was doing it. And the nurse manager said, you don't know, Carol, her numbers are great. And I'm like, she's not doing well. And that was documented in the note that I had called and everything else like that. But, kind of note to everybody, if a physician's sister is calling saying someone's not doing well, you kind of have to hear it. And they didn't. They just said she just really needs to go back to her local physicians. And so she tried. And so here you have this woman that they haven't seen for a year and a half. And she's coming, she's got foot drop, she's got, all these things going on. Her numbers are great, that's good news. But, that's really hard to fit into a local oncologist and a local primary care physician, 30-minute meeting to come in with all these issues and to be dealt with effectively. Yes, sir.
Was she admitted to the bone transplant service?
Yes.
That's where I see some of the problems.
You're right.
I think if she was admitted to a general medical ward, they kind of had I would think, I can't tell, but
Yeah, right.
they might have picked up this.
Yeah.
In the fact, because she really wasn't having problems with the transplant, she was having a medical problem.
So the neurologic issues were graft versus host. So there's still some question in my mind, were the cardiac issues graft versus host? I don't know that. I would also say, if you spend all the money to transplant someone, you still have to look at the basics, the basics. And the oncologists all are trained in internal medicine. So, they should have done something, at least pull an EKG. So they, oh yeah, or another troponin after the community hospital.
That was never explained. I never thought about. That should have been
Right, and it was the first. That was missed. So they missed a lot. And so part of the process, they had me go back. They asked me if I wanted to talk to the bone marrow chair. And I said, sure, I would love to go and talk to him. They said, on your own dime. I said, okay, fine. And so I thought there was going to be an interaction between him and me. And, he was very appropriate in saying, I'm sorry you lost your sister. And then I said, well, I don't understand. How is it, this attending writing notes where he wasn't there, and why wasn't an EKG pulled in 8 months, and blah, blah, blah. And his response, which is not one that a family likes to hear, was, I don't know, I wasn't there. I don't know, I wasn't there. I don't know, I wasn't there. So I flew down to Northern California to hear, I don't know, I wasn't there. And, it just makes you madder. It's just like, why don't you know,
I'm sitting here listening to this as somebody who was trained in a different era, and I don't think that we have really sat down and thought about how much the paradigm of medicine has changed from in the last, especially 30 or 40 years. At that time, when you were trained that you had personal responsibility for that person under your care, and that anything that went on with them, you should be involved with. There were very few even specialists at that time. There were very few, most of it was either private pay or, you know, an extension of private pay. There were no physician extenders. There were no healthcare systems that demanded that people go to different contracted groups. There were no, business was not in total control of medicine the way it is today. And I think that plus the things you're talking about with the medical records, where people spend 50, 60, 70% of their time working on the medical record rather than working on the patient, is bound to cause these kinds of problems. And we haven't caught up with ourselves with our own paradigm shift. We have created a situation where not only can mistakes happen, they are almost guaranteed to happen. And I've been an advocate since I retired for several family members, as you have been, as they have gone through the process of cancer treatment or other critical issues. And it is routine that things are missed, that people are not listened to, that they don't have the note from the prior person, even despite the medical record, etc. So this medical system needs to catch up with its own development, or this is going to not only continue, it's going to get worse.
Thank you for that. Yes, and one of the meetings I had with the inpatient attending when I was talking about the medical records, he said, "Oh, you don't understand, the medical records are for billing." And I said, "No, I do understand, sir. The medical records are not just for billing." And, you know, I think we have gotten a little bit skewed at times, and that causes, and there has been a paradigm shift. And, you know, I mentioned that my own father was a physician in one of the families we grew up with. That man was the residency director for family practice down in Ventura County, and, you know, they're like cousins to me, and they'd said, well, you know, Dave and your dad would be turning over in their grave if they ever heard what happened to Anna, you know. So, I mean, and I know that. I know my father would be just mortified to think that she had the care she had from the medical profession.
Is it standard of care at this particular hospital to have such a delay with the cardiologist and the echo? Because I find, of all the missing steps, I find that really, I guess, the most shocking, that a consult was placed and it took 5 days for a cardiologist to come and see. So what did they explain to us as the reason why?
Never got an explanation. Yeah. So I asked them for institutional changes, okay? That is what I asked for. I've never heard, what I've heard that is they've added a nurse to the rounding team and they've added another rounding team. That's all I've ever gotten back from them.
Yeah, I think it all comes down to communication, okay, from the primary care doctor and being involved. And again, in fact, I've been in practice a long time, but as we went to the hospitalists and you no longer went to the hospital as the primary care doctor, and communication between the hospitalist and the primary care doctor and what's going on. Because, you know, the primary care doctors now and pediatricians and everyone else, they don't go to the hospital. You know, they don't go see their patient during this time. They're not there to advocate for their patient. And communication between the hospitalist and the primary care doctor is not there. And I think that's where it all falls apart.
So we've had a paradigm shift, you know, like he was saying and like you're saying. But even with that paradigm shift, then we now have to change and figure out how we're going to make it work. Because I don't think it's going to go backwards. I think we're going to have hospitalists from here on out. And I think we should, because some hospital medicine is so demanding that you don't want someone doing that as well as a full, you know, practice of internal medicine, you know, soup to nuts. So if we have a new paradigm, that means we need to change. You know, so I'm unwilling. I agree with you, it's communication, but we've got to figure out a different way, because all of us are in the same boat. I mean, who's going to take care of us? You know, who's going to take care of our family members and your family members?
A comment.
Mm-hmm.
Your presentation, both factually and emotionally, is the most powerful one I have ever heard as someone who listens to such things and the comments that have just been made. And I wish that there were about 1,000 of you so that every hospital in the United States could hear your presentation twice a year for the next couple of years. And I think all of us are aware of these problems, and particularly old guys like me. It's so different now, and the solutions are so unapparent that I'm very grateful for you.
Thank you.
You know, I'd like to just echo a little bit about what Dr. Dexter said and everybody else, and Dr. Ellen, because in the old days when you said you were going to order a cardiology consult, it really meant that you, the physician who wrote that the chart, were going to call the cardiologist on the telephone at that point in time and say, I got this patient here, would you please stop by and see him this morning or this afternoon? You really, it was on you to make it happen. And usually you didn't write an order in the chart for a cardiology consult. And then it happened that all of a sudden the order for a cardiology consult gets listed as one, change the IV rate, add antibiotic up to dose, and then, by the way, cardiology consult. And you walk off and leave it. Now, most of us didn't do that. But in fact, that happens not infrequently in many institutions where the consult is written as an order. And then it is dependent upon the electronic system to communicate that order to whoever is supposed to receive it. And then you don't know how that really flows and how long it takes to get to the person to receive it and with what level of urgency and how it's triaged. And that's different from one institution to another. So that's hugely important about getting back to communication. We don't take the responsibility to communicate with the other person who needs to be there to make that consult. It's on us that we fail the patient. And if you've all been watching the news lately, now institutions are having their medical records system hijacked, where it all falls apart. You don't have access to medical records and your orders for all that kind of stuff. And unless the hospital is willing to pay a ransom, they don't get their medical record system back. And it just happened in a hospital in California.
Yeah, it did.
I'm sure you're well aware of that. And we're going to see more and more of that. So we need to pay attention to this communication thing. Doctor to doctor.
I think that it all comes back to personal responsibility for the patient and continuity of care. Because somebody has to be where the buck stops. And if they're not, if they don't, then care gets so fragmented. It's not that everybody doesn't want to do a good job. It's that care is so
Yep.
fragmented that there's nobody who is pulling it all together and saying, okay, that's fine, but there's this other problem that's not part of your spectrum.
I agree with you. I would also say this is, I think we're putting a lot on our providers right now, and they want to be able to do all that, but we haven't figured out a way to give them the bandwidth to do it. So it's not that they don't want to do it. I think we haven't given them the bandwidth to be able to do it well. And maybe, if you just keep loading stuff on them, things go, I agree. No, listen, I agree.
It's a team.
It's a team.
So the
Yeah.
communication needs to be within the team, but if there's not a person with ultimate responsibility or a system to guarantee ultimate responsibility to somebody
Yeah.
who's that person's advocate and caregiver, then I don't care what the team works for, it's going to break down.
Yeah.
I think that's, fair to say in terms of ultimate responsibility. I think a part that you noted in your slides that I think we haven't really spoken to because I don't think we know how is the complexity of medicine, right? The increasing complexity and the fact that your sister survived a bone marrow transplant, done so well, and in the light of the chest pain that was having graft versus host disease, all of these
Yeah.
areas of medicine that didn't exist
Yeah.
a few decades ago, and probably that no one physician can be master of.
Yeah.
And so it's figuring out, sure, how do we put together the minds that may be able to manage one piece versus another. And I think sort of feeling like, gosh, one person dropped the ball or nobody wants to be responsible is a little bit oversimplified.
Oh yeah, absolutely. They wanted her to survive. No one was, there are those weird cases where people don't, but they did. So, one last question. Yeah.
Well, it's a teaching hospital, so this is a teaching event. does that hospital do it at all?
They do M&Ms. So one of the things, because of the Pearl process, they said, we've never had a family member go back and speak to the group during one of their M&Ms. We're willing for you to go and speak to us at the M&M, but we will not re-review her case, which was very interesting. So I was the first family member ever to go and speak. I did do it. And I also, so I just shared the story and said, I need you to hear this, and I need you to hear about the medical records, and I need you, to communicate more. And then I also spoke to their risk management team. So did they do a great M&M? Probably not, because they didn't find, the pathologist who did the autopsy didn't find stuff. So, he didn't note that it took days for the consult, or days for the echo. So I think, they were just trying to, what caused her death? And then they said atherosclerotic disease. And I said to him, did you see any of the outside records? Did you look anything, more than her last 2 weeks of life? And he said, no, I looked at the last weeks of her life. So, thank you. Thank you.